please note that using a registered phone number is compulsory. Make sure to create a strong password. Once you have done that, click on the Finish button to be redirected to input the 6-digit verification code. Get this code sent to your email or your phone number and click to verify the button to complete the sign-up process to get started on NaviHealth. Once the sign-up process is complete, search for a healthcare service close to your location, and once the result pops up, you can search for a facility close to your location. Once you search for a facility, you can click to leave a review on that facility. Make sure your reviews are 100% authentic and original. Input a display name which is not your profile, and thank you for using NaviHealth. Hello, in this tutorial.
Thank you so much. Just also to mention that we have developed a learning management system where we encourage asynchronous learning in addition to synchronous learning opportunities such as this, and we will be sharing more information on this as we go along. So please be on the lookout to get information on how to sign in. And so today we're going to hear a quick opening or goodwill remark from Dr. Seyi Oyeshola. Please forgive me again if I have mispronounced the name. So please play it. It's an audio recording, but it kind of drives home the spirit and the passion behind this wonderful work.
Hello and good day to everyone. My name is Dr. Seyi Oyeshola. DFC was started when a conversation took place between Dr. Tosin Majakodomi, the medical director at Uracare, and myself. It was thought that we would benefit as a group from associating with like-minded people. And when I say like-minded people, I mean doctors, Nigerian doctors who have trained abroad. Nigerian doctors who have trained abroad not only have a slightly different education, but also have quite a different orientation. And we felt this orientation was key and would be quite useful if we kept in touch on a regular basis, shared experience, shared knowledge, with a view to supporting healthcare in Nigeria as a whole. We continue to wish you a good deliberation on this, our first outing for our regularly planned seminars, webinars, and podcasts. Dr. Andrew Agon has taken the lead, and I hope and pray that you will give him all the support that he requires. Thank you very much.
Thank you so much, Dr. Seyi Oyeshola. I don't know if we have Dr. Ajayi Obe on the call. She is the lead for Sub-Saharan Health Solutions Nigeria. I think I saw her join the call. Is she on the call, please? Or do we have Nifemi on the call? And would you like to speak just a quick goodwill message as part of the organizing team as well? Yes. Dr. Ajayi, please, you can unmute yourself.
All right. Hello, everyone. I'm Dr. Dayo Ajayi. I'm a consultant pediatrician. I'm part of DFC, but I also lead as CEO in Sub-Saharan Health Solutions Nigeria Limited. We know that Sub-Saharan Africa needs lots of solutions, and they tend to be very specific to the needs that we have. We are currently running projects in bridging the gap between the formal and informal sector. As you know, there's a large healthcare informal sector in Nigeria, and we believe that we have to deal with the issues in the informal sector and bring them in line with the formal sector. They're two parallel sectors. And we're delving into understanding them and bring them on board. At least 85% of the population actually go to the informal sector. If we're going to change our indices, we're going to have to begin to work with them. We're also involved in with governments, educational institutions, civil societies, NGOs, and pharmaceuticals, collaborating with them and also providing services for them. We have ethnological expertise. We also do a bit of pharmacoeconomic, health economics and pharmacoeconomics. And we've got a specialty when it comes to hospital management, when it comes to the hub and spoke model. So we look forward to having relationships with you, a very strong corporate social responsibility as well. And we hope to engage in the future. Thank you.
Thank you so much, Dr. Ajayobi. Great to have you here and have you here on time. We have, you can follow us on social media, where you can get information on future sessions coming in and more information on DFC, Sub-Saharan Health Solutions, and MDOC, obviously. Okay, just by way of announcement, Sub-Saharan Health Solutions will be providing CPD for the doctors who have joined this session. So we ask that you please ensure that you participate in the different aspects of the session, and then we will be reaching out to you via your emails to ensure that your details are correctly captured, and we can begin processing your CPDs. Just in terms of housekeeping rules, we would like again to encourage everyone to put on your video so that we all feel like we're in the same room. We would ask everyone to please feel free to use the raise hand function or type your comments and questions in the chat. We have kept everyone muted just to be able to reduce distractions during the sessions or interruptions. We would like everyone to please be respectful with your comments and respect other people's comments, because everyone's opinion is valid. If you're having any technical issues, we have Roderick on here, as well as Matilda, who will be supporting, and we'll put their details in the chat so that you can receive any support that you need. Okay, in terms of the agenda today, we will go straight from here to doing a pre-quiz, and then we will go into the didactic of the day, covering the topic benign prostate enlargement, treatment, and current trends. We will then talk about a number of cases. We will answer questions, have discussions. We'll do a post-quiz and a reaction survey, as well as the announcements and wrap-up. It's important that we are here and we invite as many people as we can, because this is a rich session. We have experts on this call who will be walking us through different cases and just facilitating that learning around this topic, thinking about the current trends, thinking about what innovative ways have been explored when it comes to this particular topic. So we will move on very quickly to the pre-quiz. It will pop up on your screen. So if you're using a desktop, it should show on your screen. If it is not, if you're using a desktop or a laptop, if you go to the bottom of your screen, you would see where it says polls/quizzes. If you click on that, it will come up on your screen. If you are using a mobile device and you don't have the webinar quiz showing on your screen, then you have to go to the part where you have 3 dots on your phone where you access chats. On that same spot, you would either see polls or quizzes. If you click on that, it will pop up. So please, we have about 5 minutes to take the quiz. There are just 8 questions, and they're straight to the point. So again, nobody's going to be penalized. This is just for us to know where we are in terms of our knowledge. So please make an attempt all questions, like they say in university, attempt all questions. And we will definitely take this again, and we will hear from our speakers. I would give us a couple of minutes to take the quiz. I see some answers already coming in. Well done. Well done. I see some answers coming in. I would like to ask that as many people as are on the call, please feel free to take the quiz. Again, you will not be penalized. This is just to know where we are in terms of our knowledge, and we will address these questions towards the end of the And just as we're going through the quiz, if you're joining us from YouTube, please feel free to type in your full name if you are a doctor so that we can retrieve your information and it can be used for your CPD points processing. So type your full name and your email address. That will be helpful. Thank you. I see some of our colleagues from Ghana joining. I see those from Kenya as well. If you're just joining us, we are taking the pre-quiz. Please go ahead, click on poll/quiz on your screen and take the quiz. Okay, I see more answers coming in. Well done to everyone who has completed it. We have to attempt all questions. Please attempt all 8 questions so that you can submit. Okay, yes, I see the answers coming in. Thank you to everyone who has attempted it so far. I will just give 2 more minutes for those who have started to complete. If you are just joining us, I see some people just joined. Please feel free to take the quiz. We are just doing the polls, so feel free to take the quiz. One minute, 30 seconds more. Don't overthink it. Don't overthink it. Just what the answer that you think best responds to the question is what you're selecting now. By the time we go through the didactic, discuss the cases, you'll be in a better position to pick the best answer. 1 minute more before we end the polls. "45 seconds more. Thank you to everyone who has responded. Okay. "15 seconds more and we will close the quiz. So if you're responding, hurry up, hurry up, hurry up. We don't want you to stop halfway. Hurry up and hit submit. Okay, 10, 9, 8, 7, 6, 5. This was the real clock or the real timer. Life would have been weird. 4, 3, 2, 1, and we close the polls now. Thank you to everyone who responded. Thank you. We will have a chance to take the poll again later on. Okay. So we move very quickly into the business of the day. We will be introducing our main speaker. I will be introducing all the speakers, but our first speaker today is Professor Obi Davis Ekwenna. He is a tenured associate professor in the Department of Urology and Renal Transplantation at the University of Toledo in Ohio. It's a pioneering robotic and minimally invasive surgeon, notable for being the first of African descent to perform a robotic-assisted kidney transplant globally. He's a member of the Association of Nigerian Physicians and Doctors Foundation for Care, Nigeria, also known as Doctors for Change, and the founder of the Clarion Call Care Foundation. He earned his bachelor's degree from University of California, Berkeley, and his medical degree from University of Illinois, Chicago, followed by specialized training in urologic surgery and multi-abdominal organ transplantation at the University of Miami. He is definitely dedicated to advancing surgical services in resource-limited communities in Africa and the Caribbean, having initiated a kidney transplant program in southeastern Nigeria and established advanced laparoscopy programs in Nigeria. He's committed to sustainable urologic and transplant care, and this has been demonstrated through his efforts in research, education, and service. Please, with a round of applause, can we thank Professor Obi Davis for joining us today? I'm not seeing the claps. I need to see it in the chat. If not, he'll change his mind and he will not present to us. So you better start putting your hands together if you want him to share with us his wealth of experience. Okay, I see the claps. Thank you. Okay, so we would also introduce our second speaker. Please, can we go to our second speaker? We have here Dr. Osaige, Dr. Samuel Osaige, formerly or fondly known as Dr. Sam. He's a lecturer in surgery, honorary consultant urologist in the University Teaching Hospital, and consultant urological surgeon in private practice. He trained as a urologist in Nigeria and the United Kingdom. He's a fellow of the Royal College of Surgeons, UK, the European Board of Urology, Medical College of Surgeons of Nigeria, and West African College of Surgeons. Dr. Osaige, or Dr. Sam, like we like to call him, has nearly 3 decades of experience as urologist in Nigeria and UK. His practice encompasses general urology with specialist interests and skills in endourology. That's the keyhole urological surgery, the treatment of kidney stones, prostate cancer, and benign enlargement of the prostate. So with a round of applause, so that Dr. Sam will not change his mind either, let us welcome Dr. Sam as well to the call. We also have another of our dear speakers and specialists. Please, let's move to the next slide. Thank you. We have Dr. Oluwaseun Akinola. Dr. Oluwaseun Akinola is a medical doctor. He's the Chief Executive Officer of Royan Urology. He's a consultant urologist in Lagos and is involved in residence education at the Lagos State University Teaching Hospital that I'm sure a lot of us on this call are familiar with. He's also an associate professor of urology at the Albany Medical Center in New York. His interests in urology are wide and varied and includes kidney stone disease, benign prostatic diseases, urologic malignancies, kidney, prostate, and bladder, minimally invasive treatment options, among others. He is a certified member of the American Board of Urology. He completed his BA in biology at Binghamton University and his MD at Stony Brook University and his urology residency at Albany Medical Center in New York. With a round of applause, people, let us also welcome Dr. Oluwaseun Akinola. I'm not seeing the claps here. In Nigeria, they say that they clap for here. I'm not seeing it. Don't let our speakers change their minds. These, as I mentioned earlier, are very seasoned experts who have years of experience and a wealth of knowledge and have, very importantly, a passion to transfer that knowledge to individuals such as you and I. So we truly appreciate their efforts. We also want to recognize other speakers on the call, other members of DFC, other urologists who are on the call as experts who will be hearing from at one point or another during the session. So without further ado, we will invite Professor Obi Davis Ekwena to speak. So please, over to you, Professor Ekwena. Let us know if you can hear me and if you can see the screen.
Yes, I can. Thank you, Adora, for this opportunity to present and to talk a little bit about prostate enlargement. I do want to thank my fellow plumbers, human plumbers, Shehu and Sam for joining, and other people that are on. I know we have a lot to cover. We'll try to move as quickly as possible to get to the cases, and hopefully the cases will reinforce the message that we are trying to convey about benign prostate enlargement. So, and thank you for that interesting introduction. We will not change our minds. We're here and we're happy to be here. So quickly, the next slide, please. Do I have the next slide?
Yes, I think there is a slight challenge with my DJ.
Okay.
Just 1 second. Okay, it's coming up in a second. Just give us 1 second.
Not a problem. So as we are waiting for that, I will just start by saying that in terms of what we're going to be talking about, we'll talk about just generally. I believe the audience is a mixture of some physicians, some people who may not even know what a prostate is, and I'll try to keep it as sort of simple as possible so that everyone can get something out of it. So we'll talk about what the prostate is. We'll talk about the epidemiology of prostate enlargement, and we'll give a little bit of definitions. You'll hear me talk about BPH and benign prostate enlargement, and then we'll talk a little bit about how we treat this problem. So if we can advance to. Okay, so I have no disclosures that are relevant to this talk. Next slide. And you can advance past this. This is just an outline of what we're going to be talking about. So just wait on this slide. So in terms of definitions, some of the things that we as urologists, some terms that we use and some terms that physicians use generally to describe symptoms associated with bladder dysfunction. You hear us talk about lower urinary tract symptoms. And what are lower urinary tract symptoms? These are basically symptoms related to the urinary tract. So the urinary tract is consistent of the bladder, the urethra, and adjacent organs. In males, obviously, males have prostate. What are some adjacent organs that are close to the bladder and prostate? We're talking about the colon. So the colon is next to the prostate. Some parts, sometimes the small intestine may be very close. So the subjective indicators of benign enlarged prostate can be reflected in lower urinary tract symptoms. And so that's what LUTS, you hear people talk about LUTS. Benign prostatic hyperplasia, which was a quiz question, is basically a histological diagnosis. So when we do a prostate resection, or we remove this tissue, the pathologist will look at it under the microscope and tell us that this is benign prostatic hyperplasia. Hyperplasia is a term used to describe sort of enlargement of cells. And so when prostate cells enlarge, that's called prostate hyperplasia. It could be benign, meaning that it's not cancerous. So again, what we're talking about today is non-cancerous enlargement of the prostate. And so BPH is a histological diagnosis. Benign enlargement of the prostate, or benign prostatic enlargement, is sort of the technical term that should be used when we describe symptoms related to enlarged prostate. So prostatic enlargement due to BPH. Okay, so this is very important to sort of understand as one manages patients with benign prostatic enlargement. And then bladder outlet obstruction is, related to obstruction during voiding, which is, related to decreased flow. So when the bladder outlet, or where the opening where urine comes out, so the prostatic urethra, or just the urethra is obstructed, you have very high pressures within the bladder and then very low flow. So imagine, you have a water hose that's, is pinched off, and there's a little bit of drippage from the water hose, and there's a lot of pressure build up behind that. So that's what bladder outlet obstruction is. Can you advance to the next slide, please? And so, yes, next. So this slide, basically what I want to, go back, please. So the main point of this slide is that the prostate is mostly composed of fibromuscular stroma. And when this area gets enlarged, there's a lot of sort of contraction that leads to obstruction, okay? And the other thing is that the function of the prostate is to really produce about 15% of the semen volume, and this allows the sperm to sort of make it into make it through the vagina, and then allows for the sperm to then fertilize the egg. So it carries some nutritious component for the sperm, and that's all the prostate is there to do. So some people will wonder, well, why do we even need a prostate? So after people have symptoms, the prostate is after a certain age, when maybe past reproductive age, the prostate really has minimal function per se. Next slide. Keep going, please. So in terms of prevalence, who gets BPH, or who gets benign prostatic enlargement? The data shows that about 60, if you're 60 years old, 70% of men who are 60 will have symptoms related to enlarged prostate. 80% of patients or men who are 70 years old will have symptoms, excuse me. And even as young as 30-year-olds, you can have patients who have symptoms or lower urinary tract symptoms, and we'll talk about what those are. And so it's, this is not an uncommon issue, okay? So having an enlarged prostate is not an uncommon issue, all right? And again, remember, this is not prostate cancer. We're not talking about prostate cancer. We're talking about benign enlargement. So in the United States, it is estimated that 11 million men suffer from symptoms that are symptoms of BPH. Okay, so what are the contributing factors? I already mentioned one, age, right? So the older man gets, the more likely that they will have benign enlarged prostate, okay, or benign prostatic enlargement. And then what are some other things? Well, some people believe that testosterone plays a part. And matter of fact, there's a particular hormone called DHT, dihydrogen testosterone, which is converted from testosterone is converted to DHT, and that is believed to play a role in the enlargement of the prostate. So there's a hormonal component, and then there's age factor. Next slide, please. And Ms. Adora, please let me know when I'm at 10 minutes in, okay, please.
Yes, absolutely.
So as I mentioned, there's sort of when someone comes in with lower urinary tract symptoms, so symptoms related to their urinary tract that is bothersome. So the first thing you see there is that in this algorithm is how do we manage patients who have symptoms related to their lower urinary tract? Well, we really want to assess if they have bother. Okay, so some people may come in, they have frequency, they go to the bathroom quite a bit. They have urgency, they have to run to the bathroom, or they get to the bathroom, to the restroom, and they have hesitancy, meaning you get there, you have to wait a little bit before the urine comes out, or they have to push. So, but some people, it may not bother them, right? So if it's not bothersome, sometimes we, obviously when someone comes in, we want to obtain a history, a complete history to understand what their symptoms are. We do a physical exam to make sure, to check them, to do a thorough physical exam and assess them properly. And then we administer, I encourage everyone to really use this if you're in primary care or, specialized. I think using the International Prostate Symptom Score is a good way to assess where a patient is in terms of the urinary symptoms. So somebody comes in with the urinary symptoms, is a simple little sheet, which I'll show you in a minute, that can be used to assess where that person is. And this can be adopted. I believe that it has been adopted even in the Nigerian setting or in Kenya or, in different languages to assess this. Is a very, very important tool. And then obviously you want to perform a urine analysis to make sure that the person does not have an infection. And if possible, one can even measure to see if there's any urine left over in the bladder after the person has voided. And then so there's an algorithm, sort of a pathway that one can follow. And it's important, I think sometimes these things are not followed all the time, but when patients come in, I think it's good practice to sort of go through the steps. And it usually, you won't miss how to sort of manage them. And so, again, it involves evaluation. Well, maybe the person needs medication or they need surgery. Do they have blood in the urine? Are they complicated patients? That allows you sort of a way to look at what to do for that patient. Next slide, please. I'll try to move quickly.
Yes,
and again, thank you. So the important thing here that I want to point out is that guidelines are important. And why they're important? Because it standardizes care. You base your practice based on evidence. It also centers the care to the patient. So a patient comes in, well, you really want to look at that patient individually and see what it is that that they need. And then, resource utilization. So what we have here where I practice in the United States, or when I'm in Nigeria practicing, or what Dr. Shehu or Dr. Sam uses may be different just because of our location and what's available. So it's important to sort of, use guidelines. And again, I'm not saying that patients all over the world should use the same guidelines, but it's important that within that within each country or within each community, that they determine what works and what should be applicable. Next slide, please. So we're going to move a little bit faster here. So next slide. Actually, I'm sorry. So yeah, so stay here. Next, just populate the slide. Go ahead. Fantastic. So in terms of management, medications, these are some of the medications that we use to manage patients who have benign prostate enlargement. Again, we use alpha blockers. These are some examples here. The alpha blockers basically relax the smooth muscle or the passageway where the prostate is or located, and that allows the urine to sort of easily flow. The other medication that we use is called an 5-alpha reductase inhibitors, which basically shrink the prostate. They basically tackle they work two different ways. So you may see a patient that will benefit from using both, right? Where one tackles shrinking the prostate over time, and that usually takes about 6 months. The alpha blockers will work pretty quickly. So within a few days, those are working and helping relax the passageway. And these are some examples. Next slide, please. And then, so if medications don't work, then obviously surgical intervention is the next option. And what is the fundamental role of surgery? Well, the role of surgery is basically to remove the tissue that's blocking the passageway between the bladder and the urethra. So the prostate is in the way. You go in and you basically shave it off, or you remove it, and to create a larger channel so that the patient can urinate better. And the ways that we do it either minimally invasive, using a camera through the urethra. We go in and we remove the tissue that way, or we go with what we call a simple prostatectomy. This can be done in an open fashion, meaning the traditional cutting the patient open, finding the prostate, opening the bladder, finding the prostate, and sort of coring out that tissue that's blocking the patient. And as I said, it can be done in an open fashion. Some people do it laparoscopically and or robotically. Next slide. And so this slide just says, when is it necessary to operate on a patient? Okay, when is it necessary? Well, if patient comes in and is not able to urinate, so that's an indication. So if someone comes in, they can't urinate, and you have determined through the process, the urologist has determined that this person's issue is benign prostate enlargement. So it's not a cancerous situation. Then that's a good time to do surgery. And I'm just saying surgery just generally because the urologist will determine what appropriate surgery is necessary, right? If there's a stone, a bladder stone in the bladder, why do bladder stones develop? Well, if the person is not emptying their bladder very well, then they have a nidus, meaning they're at risk for developing stones, and so stones can form. Azothemia or uremia, their kidneys fail, for example. So remember, the bladder is a storage organ, right? It's just a reservoir. So if the reservoir is not emptied, then the urine will back up into the kidneys, and if it backs up into the kidneys can shut down. Okay, so if someone comes in with symptoms of kidney failure related to a prostate obstruction, then that person needs surgical intervention. Medication will not work. Okay. If someone comes in having recurrent urinary tract infections every time they have an infection in their bladder, that person needs surgical intervention. If the person comes in again with blood in their urine, recurrent, that is also an indication for surgery. If that person has worsening lower urinary tract symptoms, they can't hold their urine and they have been taking medications for a while, that is an indication for surgery. So these are sort of the 6 indications for surgery, regardless of where you live in the world. I think these sort of these are the key things to remember. And I'm curious to hear what Dr. Sam and Dr. Shane would have to say, because there are people now that believe that enlargement of the prostate is a surgical disease, period. Meaning, taking medications do not necessarily help, because typically patients will progress and have a bad problem later on. Next slide.
You have 4 minutes more.
Perfect. We're going to move forward. I'm not going to go into the details of the procedure. Just keep moving. This is just talking about the procedure. And this is slides that I use for resident teaching. So we'll just move forward here. All right, good. Step back, please. 1 slide back. I just want to talk about surgery. So, when in training, Dr. Shewa, you probably can relate to this, and Dr. Sam, a chance to cut is a chance to cure. That's what surgeons say. So we believe that most of the time it's when we say that it's time to operate on a patient, that's because we really want to cure them. And however, surgery carries morbidities. I always tell patients this. Okay, so whenever whenever we're going to go on surgery, there are complications that may be associated with it. And so also when we do a TURP, TURP means transurethral resection of the prostate. And so there's an older way of doing this, and this is called monopolar. That's what the M stands for. And so with monopolar, we use water or glycine as our irrigation. So there's this water thing that we flow through the camera, and we use it to be able to visualize the bladder and the prostate. And then we go in and we resect the prostate. Excuse me. So when we use that method, there's risk associated with it. There's a newer method. We'll talk about that a little bit. It's not so new, but I think in Nigeria it's sort of beginning to filter in. But the point of this slide is that, look, there's a risk of mortality with any surgery. Okay, so these are people that these are sort of older series. Newer series, still there's a less than probably 0.1% chance of something bad, like someone dying after a surgery. That can happen, but it's very, very low risk of having mortality, right? There's a risk of what we call TUR syndrome, where because of the water that we're using to do the surgery, that can dilute the electrolytes within the person. So sodium can really go low, and there's sequelae from that. Transfusion, so patients can bleed, and the risk of transfusion in these series are less than 2%. I'll say now the risk of transfusion is probably less than 1% in some of the more current series. Risk of reoperation, so after the operation, somebody may need another surgery. The risk of operation is less than 5% most of the time. So these are these are minimally invasive ways of doing this procedure, meaning there's no cutting, right? We're not cutting the person open. We're doing it through a camera, through the urethra, so all within. I believe Dr. Shehu and Dr. Sam, they provide these services in Nigeria. And so next slide.
1 minute more.
Perfect. And then so bipolar TURP, again, is an alternative. So keep going. And so laser prostatectomy, sometimes we can use a laser for this. There's surgery as well. Keep going. And there are different types of lasers that are used. I'm not going to belabor this point, but the point is that there are other ways of doing the surgery. Keep going, please. And the outcomes are very, very good. There's something called HOLAP, which is also used. It's a newer way of removing the prostate. And you could do it for very large glands or for even smaller glands. Keep going. Going. And as I said, with every surgery, there are complications. So let's go to the next slide. And then, so let me just talk quickly about these. These are other minimally invasive ways of removing this enlargement, the prostate enlargement. So this is called tuna, or is just basically you go in with the camera, you use a needle, and you find that area where the prostate is enlarged, and you basically bring in radio frequency energy, and that heats up the prostate, basically cooks it. And eventually that area kind of sloughs off and there's a big channel that's created. Next slide. Again, these are minimally invasive ways of doing it. And then another way is doing microwave treatment. And then I'll just spend a couple of minutes on this one. So this is sort of maybe within the last 5 years that we started using UroLift. Basically this allows, so you can see in one of the slides there, I don't know that you can see my pointer, but the picture to the left shows you an enlarged prostate that's kind of squeezing on the urethra. And then the step 2 is basically you introduce a camera. The camera comes in, and then you use a pin. It's like most of us have curtains. You basically pull the drapes aside, and it gives you an opening. So that's what you see there. So these are little pins that are used to sort of attach the prostate to the sidewall or to the capsule, and it gives you a nice little channel. There's some advantages to this, with some of the procedures that we mentioned earlier. You can have what we call retrograde ejaculation, where the semen does not propel forward. It's not a disaster. It's not a problem per se, but some people that want to preserve ejaculatory function may be eligible for this procedure. So this is sort of one of the newer ways that we treat benign prostatic enlargement. Next slide. Sorry, Dora, I'm going to need about 5 minutes. Next slide. And so, yes, go back, please. I'm sorry. So this is another way. You can imagine, again, the idea, for some of you with that are innovators here, the idea basically is to figure out a way to reduce that enlargement, that area that's squeezing on the prostate, right? And so some people have come up with even using steam. Okay, so you bring in this camera into the prostate, and then you inject steam into the prostate so that it basically kills up that area that's enlarged. Water vapor, basically, that's what this is. So you bring in this machine, you inject it into, and then next slide. This is called Resume. There's another fancy way of treating benign prostatic enlargement. Next slide, keep going. And people have, the data shows that these are very, very good, have shown very good results. This is another way. Olympus came up with this. This is called iTend. Basically, there's a temporary, unlike the other ones, unlike UroLift, this one is a temporary nitinol device. Basically, you put it into the prostate. It basically stretches the prostate. You keep it there for about 5 days. Patient comes back and you pull it out, and it leaves that deep defect in picture number 3. And patients actually do very well. I've done quite a few of these, and the only caveat is that they have something hanging out of their penis for a few days. Next slide. And so next slide. Again, the results are pretty impressive. So this one is the newest one. Go back, please. I'm just going to talk about this a little bit. So this is aquablation. Okay, so let's start aquablation. Aquablation is basically, imagine that you have a, you're power washing your floor with a, very pressurized water hose. Okay, so that's basically what this is. This is robotically guided water hose that basically ablates the prostatic tissue. This is fantastic technology that is, I think, it's probably I will say probably 3 years old, but now being more adopted. And basically, you just go in, you identify the prostate. Next slide. So, next slide. God, I thought I had a picture. Okay, good. So stay on that one. Go back. Go back one. No, go back. Go forward. I'm sorry. I just wanted to talk. Okay, yeah, there you go, right here. So there's been trials called water trials that have shown excellent outcomes. And so if you look at the picture on the lower end, you bring in a camera. Again, this is done inside, from inside, through is basically through natural orifice, the urethra. You bring the camera in, and you park this the camera with the probe in, and you push a button on the computer, and basically it ablates all the tissue. And the first trial did it for prostates that are not so big, 80-gram prostate. I should say that the normal size prostate is about 25 grams, and people say, what is that? What does that mean? Well, we say walnut here, but I guess, Dr. Shea, what do you usually tell your patients? The normal size of prostate in Nigeria, what do you tell them? You can unmute yourself.
I tell them it's the size of an almond fruit.
What?
Okay.
A what?
Almond fruit.
Almond fruit. Okay, fantastic. So, this is about maybe 3 times the size of an almond fruit, I guess, right? And so this studies have shown very, very excellent outcomes. And the other thing is that it preserves ejaculatory function. Okay, so which is, some men desire to keep that. Next slide, please. I think I'm almost done.
Hi, Dr. Obi. Time up.
Time up. Okay, let's keep going. I think I'm done. I just have one. Let's keep going, keep going, keep going, keep going. There are other things. This is called Uptolume. There's stents. And then there are medications that are being used to sort of stop prostate enlargement. So let's go back to one slide, please. All right. So in terms of, this one, stay here. So the current trends, as I said, there are drugs that are being introduced into the prostate. There are advanced minimal invasive techniques that have been mentioned. And, there in the future, there are what we call personalized medicine, where patients will come in, you figure out exactly what is the cause of their issue, and then you can tailor medications exactly for that patient. Next slide, I think. And then obviously, what's good for the heart is good for the prostate, I tell patients. So a good diet is important, exercise, drinking plenty of fluids. Complementary medicine, I would say, this is just an old slide, but I would, be cautious about using, things that are not well studied. Next slide. And obviously, medication, there's medication trial, you can try medicine first, oral medicine, and obviously surgical treatment. And again, the point I want to make is that surgery is very, very safe. Okay. In the right hands and with the right person doing the surgery is a very safe procedure. And with the right evaluation, I think, one can overcome some of the symptoms associated with this. So with that, I think I'm going to end. Thank you for your attention. I know it was a lot to cover in 20 minutes, but it's a pleasure. Thank you for paying attention.
Thank you so much. Please, round of applause for Professor Obi-Ekwena. Thank you so much. We will be sharing the resources, so don't worry about the slides that were skipped. There's a lot of information. There's a lot when we speak about the trends. I see a comment in the chat that says the local walnut currently in season in southern Nigeria is an easy item to compare to normal prosthetic size. Thank you so much. I think that's from Lekon Ajay. Thank you so much for that. So we'll move very quickly to the first case. Please just to note that you can send in your questions in the chat. As we go through the case, we'll give one or two people the opportunity to ask their questions, or mute themselves and ask their questions, as well as make their comments. So we'll be going very quickly to the first case that will be presented by Dr. Sam. Welcome, Dr. Sam. Please take it away.
Mute me, please.
Yes.
Good. Thank you very much, Adara. And it was very interesting listening to Dr. Obi Ekwina's presentation. He gave a wide selection of cases. Just the general aspects in terms of treatment options. Unfortunately, he didn't have enough time to talk about all that. I thought it was very interesting. But I will go straight to the cases, which I think the case selections we have try to illustrate some of the ways, the common ways that we do see the patients in Nigeria. Next slide, please. We got a 62-year-old man. He presented to the emergency room, inability to pass urine with associated pain. The lower abdomen was distended. For years, he had had urinary symptoms. And the next slide, please. He had been on medical treatment, as Dr. Ekwina illustrated, also for years. And in the past, he had transient episodes of urinary retention. He had a catheter was removed, and as usually often happens, he was able to pass urine. He had normal sexual functioning. Next slide, please. There was nothing of note in the medical history other than his hypertension and diabetes, which were well controlled. He was married with 6 children in a monogamous setting. There was nothing else of note in the social history. The next slide, please. So, the main finding on that occasion of his emergency admission was a tender lower abdominal swelling up to the level of his umbilicus, and a bladder scan revealed a volume of about 900 mils in his bladder. On rectal examination, the prostate felt large but clinically benign. The lower limb neurological examination was grossly normal. The next slide, please. In summary, this was his 3rd episode of acute urinary retention, presumed due to benign enlargement of the prostate causing obstruction. Secondly, he has had medical therapy, which obviously haven't been successful, as he has been having recurring episodes of retention. He did have a size 16 French urethral catheter, passed easily, and about 850 mils of urine was drained from his bladder. And that gave him instant relief. The basic investigation tests were normal. The PSA was normal too, within the reference range. The next slide, please. That was a transrectal ultrasound assessment of his prostate size, about 70 grams in size. Next slide, please. That's the transverse and the longitudinal. So again, just to reiterate, the context we have here, it's a gentleman with failed medical therapy, recurrent painful urinary retention. And as mentioned in the earlier presentation, this fell within the indications for surgical treatment of his benign enlarged prostate. Thankfully, that was acceptable to him following counseling. He did give consent and had uneventful transurethral, it was actually a bipolar transurethral resection of the prostate, resetting about 40 grams from his prostate. And the histology was benign prostatic hypertrophy. Benign prostatic hypertrophy. And then following the removal of his catheter after the surgery, on the occasion of the removal of the catheter. He managed to void 404 mils at 23 mils per second with a normal flow pattern, and the post-void residual, the amount of urine left inside his bladder after urination, was only 15 mils. And that's the flow curve after that. Yes, that is the flow curve. That's the plot of the volume of urine passed over time. It's a very useful tool for us in the bedside assessment or even outpatient clinic assessment of men with lower urinary tract symptoms. The next slide, please. And I have another quick case, 71-year-old man. He presented to the urology clinic, not to the emergency room this time. 2-year history of difficulty in passing urine. He had both storage and emptying voiding symptoms, which were uncomplicated. He was severely symptomatic with the symptom score 23 out of 35, and it was significantly impacting on his day-to-day activities, the quality of life or border score of 5/6 or unhappy. He did mention that his father and his brother had similar problem of benign prostatic hyperplasia. A review of his systems was unremarkable. With the help of oral therapy, he was able to improve his erections. And next slide, please. And his only medical therapy was, of course, the drug therapy to improve his erections. He was married also in a monogamous setting with children. He had no desire to have more kids. He neither smoked nor consumed alcohol. Abdominal examination was unremarkable. And rectally, the prostate felt again enlarged and benign. There was nothing to suggest neurological deficit. Next slide, please. And in the outpatient clinic, he had a urine flow test. He managed to void 276 mils at 8 mils per second with a residual of 109 mils, which clinically is not considered significant, really, but noted. Again, a plot, the uroflowmetry showed, it resembles an obstructed pattern. This is an obstructed flow pattern on the plot of the volume passed, over time. The next slide, please. So these were the basic. He had normal renal function. The urinalysis was clear. There was no sign of infection in the urine, and the PSA again was within normal, 2.3. The next slide, please. And clinical diagnosis, severe lower urinary tract symptoms presumed due to benign prostatic obstruction. He was counseled on the management options. And if you remember the first presenter, he referred to self-management measures, the use of drugs, and the use of surgery. Here was a gentleman with severe symptoms. So, you could go straight to surgery, you could give him drugs, and of course, self-management would always apply. But many men, as often happens, many men don't want to rush to surgery. They want to try self-management, they want to try drug, which is what he did. So he was instructed on fluids to avoid, regular emptying of the bladder, the bladder drain. He was started on alpha blocker medication. Obviously, he declined the other group of drugs, the prostate shrinkers, because of concerns about sexual functioning, concerns about impotence. Next slide, please. So about 3 months following starting the alpha blocker medication, there was a marked improvement in the urinary symptoms. The symptom score had improved from 23 to 9, and the border score has also improved from 5 to 2. It was now feeling mostly satisfied. And a repeat of the urine flow test shows a trend towards the normal pattern on a voided volume of 306 mils and a peak flow rate of 20 mils per second. The post-void residual now has reduced from about 109 mils to 30 mils. So this was obviously a satisfactory outcome from the initial trial of self-management measures and drug therapy. And it was followed up routinely in the outpatient clinic. Next slide, please. I think that brings to the end of the initial cases. And my colleague will take another aspect of the clinical presentation now. Thank you.
Thank you so much, Dr. Sam. So we will be moving on to Dr. Oluwaseun Akinola. Please go ahead, sir.
All right. Thank you so much to the previous presenters. Very interesting cases. My case is that of a 56-year-old gentleman who I saw a few months ago after coming back from the US with complaints of a recurrent bladder stone. He had been urinating, not really bothered by many symptoms. He did complain of occasional incomplete emptying sensation and waking up at night 2 to 5 times. But what really took him to the hospital was that he noted he had some sediments in his urine. He had no history of kidney stones, no blood in the urine. He had previous surgery for bladder stones in Florida in 2023. And of recent, he had started straining more to urinate, which led him back to the hospital when an ultrasound was done, showing that he had bladder stones. So can we go to the next slide? In terms of his medical history, he was hypertensive and diabetic. He had had an appendectomy prior, and as I mentioned previously, he had a cystolithopaxy, which is laser surgery for kidney for bladder stones in 2023. No contributory family history. He was not a smoker, but used alcohol socially. Was on amlodipine and valsartan for his blood pressure. No allergies. Next slide. His examination was really unremarkable, except for a prostate that was about 70 grams inside, an estimated volume of 70 grams. But it felt benign without any concern for cancer in the examination. Next slide. His PSA was 5.2 in January this year, which was okay for his prostate volume. He had an ultrasound that showed that he emptied his bladder pretty well. And a CT scan had been obtained, which showed multiple stones, about 7 stones within the bladder, and confirmed the size of the prostate to be about 96 mils. So, I wanted to just do this a little differently. I think it might be of value to have the, urologists just comment on their thoughts and how they would manage, and, and then we can learn from all of that. And I could say what we had, what we did for this patient at the end. Obi, if you'd go forward.
Excellent. So a 57-year-old, let me just rehash what you said. So 57-year-old who had had a previous bladder stone treated, pretty healthy otherwise, had, I think you mentioned high blood pressure was the only comorbidity that I noted.
Diabetes.
And diabetes. Okay, so had diabetes as well. So so that may, and diabetes is type 1, or type 2, I'm sorry.
Type 2. Type
2, okay. So
well controlled.
Well controlled, okay. So with this type of patient, you have a large prostate, so that is I think the main culprit here. When someone has diabetes, if it's long-standing diabetes, I always sort of get kind of concerned if there's a diabetic bladder going on as well. So, when someone has a diabetic bladder, they may not be emptying their bladder well, which also could be a nidus for stone formation. But in this situation, what I'm thinking is, will this patient benefit from a urodynamics or not? Whether that changes your management is up for debate. But yes, I would say that this patient definitely based on the guidelines, based on what we talked about, will benefit from surgical intervention for the removal of both the stones and resecting the prostate at the same time. So that's what I would do. I'll probably do a TURP and remove the stones. One question I have is I don't remember if you have done a PSA on him.
Yes, his PSA was 5.2.
5.2. Okay, so
PSA density normal.
Okay, and no family history of prostate cancer or anything like that.
No. Well, he has a family history of prostate cancer, but his PSA has been very stable over the years. And, commensurate with his prostate size, the PSA density was within normal limits. We counseled about all the options and decided to go forward with treatment of the enlarged prostate.
Dr. Sam, any
So,
comments?
Dr. Sam.
Yeah, this issue of PSA 5.2, many patients will come dangling a result of 5.2 because the laboratory has written at the bottom of their results that is not to 4, that is normal. But as urologists, we know that is not always right. And I was reminded recently that they are not saying it is normal, it is only a reference range. I found that interesting. But coming back to this particular case, as Sean mentioned, the PSA appeared to be what is acceptable for his prostate size and age. The PSA density was less than 0.15. And the patient was very worried. You could go ahead and do an MRI just to see that the pirates is either 1 or 2. Then you can stop there. You might not need to investigate more. But obviously,
Actually,
the PSA
he had
density
that, yes.
was good.
Correct.
Or the MRI was abnormal. Then, of course, you want to go a pathway, the prostate cancer pathway, in terms of investigating the patient.
Good point.
Excellent. So yes. Thank you, Dr. Sam, for mentioning that. I did leave that off the slide. He did have an MRI, which didn't really suggest any significant lesions. We know that MRIs aren't perfect, but with the clinical picture in total, we felt very comfortable going ahead with his treatment. And the options discussed included what Dr. Obi talked about, going in with a camera, using a laser to get rid of the stone, and then doing what's called a TURP, a bipolar TURP, because of the size of his gland, to reduce the risk of complications mentioned by Dr. Obi earlier. And he did very well. Alternatives discussed also included, open surgery. For someone like this, with stones in the bladder over 80 cc's, that's another option. Of course, the blood loss is higher with that option, but it's also a very safe and acceptable treatment option according to the guidelines. It just few interesting cases that we come across routinely. I found out Africans, we tend to present with bigger prostates in general, on average, compared to practice in the Western world, where maybe a prostate of 50 grams would be considered big. Routinely, we're dealing with those things. And, we just have to keep all the options in mind, in addition to the constraints of cost and, people's ability to afford certain options and all of that. Thank you for allowing me to present this case.
Thank you. Interesting.
Next.
Oh, and that's just a picture of the stone from his from that patient.
The golden eggs.
Very nice ones.
That's right there. All right, next.
Yeah.
Do we have time for the third case? Adora, do we have time? Okay.
Have we lost her?
She should be there.
Hi, yes, I am here. If we can rush it in 4 minutes, please, because I see people are saying, I have people buzzing me privately that they would want to hear it, so we can go for it.
So this last case is, I'll just kind of summarize, a 60-year-old who came in with a very large prostate. His PSA over the last few months or years has been between 4 and 10. And he actually went ahead and had a biopsy of his prostate, which showed that there was no cancer. So one of the things that we want to point out is that it's important to make sure that when someone comes in with a presumed enlarged prostate, that the urologist, as you can see here, we ensure that we're not dealing with prostate cancer. And Black people, African people of African descent, there's a higher risk of prostate cancer, as you know, as we know, and screening is important. So I think I should put that in there now, that, you know, if someone is 40 years old or 45 years old, they should definitely get a PSA baseline, okay? Because the risk of prostate cancer is there. And we, as urologists, we make sure first that the person doesn't have prostate cancer before we have, you know, decide on what else to do. So this person had the sequela of you know, sort of the bad things that can happen if you don't get treated. So the patient came in with a creatinine of 8. Their kidney basically had shut down, and they had very large swelling of their kidneys. Can you just advance to the next slide? So this person is a typical person that didn't show up. Keep going. For many years. Keep going, please. And I just want to show the picture. And he was hypertensive. His creatinine wasn't working. I mean, his kidney wasn't working well. We put a Foley catheter in. So this is what happens over a long period of time. You can see that the kidneys are swollen. Those are the kidneys up there with the arrows. You have hydronephrosis, or sort of stretching. And you could, even the meat, the parenchyma of the kidney has shrunk, okay, over time. And if you look down, next slide, let me see if I got that picture. Okay, yeah, so you see the bladder. The bladder has gotten so thick, the thickness of the bladder. So this person who's dealing with not only bladder failure, right? Bladder can fail, and the kidney can fail. Okay, so the bladder can stretch, you know, the muscle of the bladder gets so thick, and you know, that causes, you know, reflux into the kidneys, and can become very problematic. So this is a sequela of not taking care of these symptoms, these lower urinary tract symptoms that a lot of men will sometimes ignore. Well, oh, I'm a little old. You know, people will say, well, I think I'm getting old, so that's why I go to the bathroom quite a bit. Oh, I can't empty my bladder as well. Well, because I'm old. That is not the case. So if those symptoms are there, please seek out, or encourage your patients to seek out evaluation by the urologist, or at least by the primary care, and eventually get referred, so that you don't end up with what we have on there. So next slide. And so this patient got a catheter, and eventually, keep going. That's the catheter in there. And keep going. And again, you know, this patient needs surgery. I mean, then, you know, ultimately, obviously, you want to make sure that they have their kidney function, and they get referred to a nephrologist. So that person needs to be seen by a kidney doctor to manage their kidney issues. And depending on your setting, you may want to do open prostatectomy, or you know, here we'll probably do either aquablation or simple prostatectomy for that patient. And you can stage it. You can go back, you know, do a resection, a bipolar resection, and then subsequently go back for a second stage. So I think that's the end of that case. I don't know if Dr. Shanwu or Dr. Sam, any comments at all on that case?
That's okay.
Yeah. All right.
No, not really. Very, very good case.
Thank you.
If you have any questions, I think we have time to hear questions or comments, but we have some in the chat. I'm just going to read one or two. Professor Obi, there's a question here that says, please, can herbal medicine be used to treat prostate enlargement? What is your advice? Most men are now using herbs instead.
I think maybe this, I think I want to hear from Dr. Zagid, Dr. Sam, and Dr. Sam. Will you guys take a stab at this? We here in my setting, yeah, some men will buy certain supplements over the, you know, on Amazon or one of the over the internet. We typically, what I say is that, you know, some of the supplements may or may not work. Okay, and it's just that I just don't know. I honestly don't know those that work versus those that don't work, because that's one, I don't know. The other thing is that, I don't know what the complications associated with those herbs are. So the standard medications that we prescribe, at least I know what the symptoms are, what what could happen or what complications can be associated with them. So I usually will discourage patients from buying things that we don't know about, that we don't know what the ingredients are, because they may carry other symptoms that may affect other organs that we can't that we don't know. So that's sort of my response to that. Dr. Sam?
Yes, of course, of course. Just as you say, those group of drugs, the so-called phytotherapy, there are quite a number of them in the Nigerian market. And not long ago, I think it was sometime last year, working with a pharmacist, we got a list of the phytotherapeutic agents in their own shop. I counted about 8, but what was common about all of them is that they all had these finasteride-like, substances. So
Right.
in other words, those are the prostate shrinkers. Some of them might have some components of alpha blocker medication as well.
Right.
Some, they are unorthodox medication. So as Dr. Ekwena said, I will not prescribe it, but I will not actively discourage men from taking it. So when you have counseled them on drug therapy, some of them are already taking phytotherapy. Some of them, you give them alpha blocker medication, they say it doesn't work. And then they go and take phytotherapeutic drugs, and they come back and tell you that is working. So there have actually been patients that reported efficacy or good result. But we see many patients who are taking it who also come back and they say they are not getting good result. And I'm sure you'll be aware of a paper in the Journal of Neurology. I think it was about 10 years ago, where the phytotherapeutic drugs in the American market were analyzed, and they found out that the doses were very diverse. They did not. There were no standards. What they claimed was the dose in the packing was different from what was found in those drugs. But having said that, that paper also acknowledged that they work for some patients, but that the manufacturers have different standards in terms of producing those drugs. And I think the latest guideline of the EAU didn't quite condemn phytotherapy. So there is some role for phytotherapy, but make sure you are getting it from a reputable supplier or manufacturer. Thank you.
I agree with that. I think I also see there's related to that is people talk about saw palmetto. There have been randomized controlled trials looking at saw palmetto, and those have not panned out. So randomized controlled trials are the best trials where you give one drug and you give a placebo and you compare to see if placebo is like maybe you give them salt or you give them a sugar pill, and then you compare it to the pill that you're interested in studying. And so saw palmetto was compared to a placebo, and it showed that there was basically this, the placebo effect was seen. And so, you can't really, prescribe saw palmetto if it's the same thing as a placebo. You're going to take a sugar pill, patient will still do as well as taking saw palmetto. And these things are very expensive. Actually, some of our older patients in the United States are targeted by these companies that they don't go through FDA approval, and they come up with all kinds of supplements, and it actually, some patients get some of the bottles are $70 per month, and it can be very expensive for our patients. So one way we tell them that this is not it's not the way to go.
So
here
in Nigeria,
the takeaway message on that to the questioner is that they are supplements. As urologists, we don't prescribe them, but if you want to take them as supplements, so well and good. They are not a substitute for actual medical treatment.
Hello,
we have
I'm Dr.
Dr. Ajayobi. Yes, please go ahead.
Along these lines, the third case, bit upsetting that this man actually had his kidneys were affected, and only God knows if he will actually regain function. Late diagnosis is a big problem when it comes to sub-Saharan Africa. How do we begin to communicate the message? And how to make it easier is if something eventually happens in most men as they age. What are we doing to communicate this matter? Is this being measured? Is this being measured in metrics? The number of cases that are coming through, the complications that actually happen as a result of delayed presentation. I suspect that the presentation complications actually are more when it comes to management. How are we dealing with this on population science level?
From my university teaching hospital practice, I can tell you straight away that it is fairly common. I cannot give you percentage in terms of what proportion, exact percentage, in terms of if you look at all the patients presenting with prostate enlargement emergencies, you will find out that up to easily 30 to 40% of them either come with bladder stone, elevated creatinine, which may be mild chronic renal dysfunction or moderate chronic renal dysfunction. The extreme situation where the kidneys have packed up in a chronic end-stage renal failure, it can happen, which is a pity. But you still see these things, especially in the poor, in the low economic class. You still see them a lot. The last I have now, this was just within the last 2 weeks, it has been counseled to have end-stage renal failure by the nephrologist, and is now faced with a life of dialysis and seeking transplanted kidneys. So that problem is there. It will be interesting to hear Dr. Akinola's perspective, on this.
Yes. So I totally agree, Dr. Sam. I think there are a combination of factors that lead to these late presentation. One is education / miseducation. A lot of patients thinking, it's a death sentence or something like that to go to the hospital because they have urinary symptoms. They've heard maybe somebody had surgery and now they can't pee. You rather see them on all these phytotherapies that we talked about. People swear by saw palmetto, the soursop. We hear all of these things. Meanwhile, there's accumulating damage. Access to healthcare is a problem for the majority of the population. Their waiting lines, to see the doctor. So there are a lot of factors that contribute to it. I think what we can do is, as much as possible, educate and that these things are treatable. Early detection, both malignant conditions, prostate cancer, which is another problem, BPH, all these things are avoidable. They're absolutely avoidable. And it's a cultural thing. It's a social, economic thing. It's going to take a lot of effort, to right the ship.
Yes. And there is still a lot of myth surrounding prostate disease in Nigeria. Almost every elderly man has a friend or a relative who has died from prostate problem. Either they went into hospital, they didn't come back home, or they went in to have the surgery and they didn't survive it. Therefore, they look for ways to manage it, without going to the hospital. And sometimes, even when they are offered appropriate treatment, they refuse, they decline it. They will only come in when they can't help themselves anymore. They're in renal failure, they got a bladder stone, or they're urinary retention. As Dr. Akinola mentioned now, within the last decade, there has been, within the Nigerian urological community, there has been a great effort to improve the management of these patients. And we can safely say today that a certified urologist in Nigeria, the chances of a man dying from benign enlargement of the prostate surgery is drastically reduced now. I think many men who have such treatment now, they survive. And that's largely due to case selection, selecting patients and preparing them for surgery properly. And I think that's where we are at the moment. And of course, more and more patients are having these surgeries done endoscopically rather than open surgery. And emergency prostatectomy is being discouraged. But those are the ones where mortalities will be high. Thank you.
Thank you so much to all our speakers and our experts on the call. We will very quickly go into the post quiz, but we will have our speakers and our subject matter experts respond to the questions in the chat. So we're launching the post quiz now. So please feel free to respond. I believe that with the cases that have been discussed and the didactic, we are now better positioned to respond to the quiz. Again, nobody will be penalized. This is just so that we can track our knowledge gain. So please attempt all questions. There are 8 questions. As you do this, our speakers will be in the chat responding to the questions. Thank you so much. I see some answers coming in. Please feel free to continue to respond. We will be rounding up shortly. We just want to make sure that everyone gets a chance to take the post quiz. Dr. Ajayobi, I still see your hand up. Do you want to say anything, ma'am, or is this from before? Oh, okay.
Just to mention, I like to put forward to you the Urology Society of Nigeria, that you'd have a communication strategy for Africa or for Nigeria in getting the message out. You get communication experts to sit down and develop a communication strategy so we can deal with this. I know in the UK, when it comes to prostate cancer, there's so much going on. And I think that it's about time that we begin to reduce the stress and the morbidity when it comes to men. Something eventually will happen. We need to get them out, give them the information, get them quickly to come forth and get sorted. Thank you.
Thank you so much.
I agree.
Okay, I see answers coming in. So if you are unable to see the poll on your screen, if you're using a desktop or a laptop, all you need to do is go to the bottom of the screen where you have polls/quizzes. If you click on it, it will pop up on your screen. And then if you're using your mobile device, the same spot where you have chats, the 3 dots on your screen, if you click on the 3 dots, scroll and you'd see either you see poll or you see quizzes. Please click on that and it will pop up on your screen. If you're still having any challenges, please let us know and we'll have someone reach out to you to support you. Thank you. I'm seeing the responses to the questions in the chat. Thank you so much. We'll be closing the quiz shortly, so I would please like to ask that everyone attempts all 8 questions, and we would read out the questions and get the answers once we end the poll. So we'll give a few more minutes for as many people on the call to respond. Okay, we will be closing this in 2 minutes. So please, we would like everyone to complete the quiz so that we can close. Two minutes more. And it's okay, even if you didn't take the pre-quiz, if you joined late or after we took the pre-quiz, please feel free to take the post-quiz. We believe that you caught a good portion of the conversation, so you should be able to respond to the questions. And please attempt all 8 of them. If not, your responses will not be captured. Okay, we're closing the quiz in 45 seconds. So if you have started, please complete it. If you are just starting, we will hope that you can quickly respond to all the questions. Thank you to everyone who had their questions in the chat. I can see the responses. Okay, 20 seconds more. Okay, we'll close in 10, 9, 8, 7, 6, 5, 4. If you are responding, we are really stalling for you to complete it. 3, 2, 1, and we will end the polls now. Thank you. And so we'll read out the questions very quickly. We'll read out the questions very quickly, and we will have Professor Obi Ekwena respond. Okay, so I'll read the question very quickly, and Professor Ekwena will just give us the answer. Okay, so the first question is, under the definitions piece, he actually mentioned this when he started his the didactic. What term is used for the typical histological pattern that defines BPH?
So,
Please go ahead. Yes.
so I think everybody, most people got that one. I think BPH. Yeah. So the question obviously answers as well, but
Yeah.
BPH is a histological diagnosis. I think we talked about that. Very well.
Yes. What percentage of prostate is composed of the fibromuscular stroma?
Right. And I think, yes, most people got this as well. 70% of the prostate is fibromuscular stroma, and 30% is glands. Very good.
At what age does BPH affect approximately 80% of men?
So 70 years, and again, most people got this correct. Remember, BPH can, or lower urinary tract symptoms can be seen in young patients as well. And the older people are, the more likely that they are to have BPH. So 70 above. Very good.
Okay. What is the technical requirement for diagnosis of BPH?
And tissue is the issue. And I think most people got this one correct as well. Maybe there's a little bit of confusion, but I'll say tissue is the issue. So tissue post.
That's a good one.
Exactly.
Tissue is the issue. That's it. You can't forget that one.
Exactly.
You can't forget that one.
Okay.
Okay.
All right.
Which of the following medications is a 5-alpha reductase inhibitor used in the treatment of BPH?
Very well. So finasteride, most people got this correct. The other two are alpha blockers. Remember, the alpha blockers relax the passageway, and the finasteride shrinks the prostate over time. So those are two ways to sort of treat the prostate medically. Very good.
Okay. Minimally invasive procedure. So what minimally invasive procedure uses microwave energy to treat BPH?
Exactly. It's in the name. These are not, they're not tricky. So transurethral microwave thermotherapy is TUMT. So that's the right answer there. Very good.
What is considered the gold standard surgical treatment for BPH?
Very good. Almost everybody got this correct.
Yes.
TRP. You hear that all the time. This is just what it means, resecting the prostate from within using the transurethral method. Fantastic.
Which emerging technology of BPH treatment uses implants to retract prostate tissue and open the urethra?
Very well. Most people got this correct as well. And that's the, using the curtain and pinning the curtain aside, the urethral lift. Excellent, guys. Thank you so much for your attention and for spending your afternoon with us.
Yes, thank you so much. I'm happy that most people got the correct answers. So we're just going to do a quick reaction survey. This is just 5 questions. This is just a way for us to make sure that we are listening to the feedback that you have for our sessions, because this is the first of many in partnership with DFC and Sub-Saharan Health Solutions. So this is just, did they meet your expectations? This is straight to the point questions about the content and the information. We would like to hear back from you, so would like everyone to please respond to this. Thank you. Okay, so this is just going to be for 3 minutes so that we can wrap up. Okay. 1.5 minutes. I just need us to give our feedback. It is important so that we'll make sure that we tailor the trainings to your feedback. Thank you, everyone. We'll close this survey in 10, 9, 8, 7, 6, 5, 4, 3, 2, just waiting for any last minute. I see more responses coming in. Okay, we have to close the survey. We would like to wrap up this session. Thank you so much, everyone. Thank you. We would like to remind everyone about upcoming sessions that we will be sending information to you via email and our flyers. So please be on the lookout. If you have any topics that you want us to address, please feel free to put them in the chat, and we will definitely collate those and take those as part of when we are deliberating around topics and areas to focus on. Just remind everyone about navihealth.ai, which is a platform that by MDoc that allows individuals find your services, use those services and give their feedback, which would also in turn then help you continue to provide quality service and ensure that you're improving the services that you provide. We will also be sending information around the learning management system that would allow you go through learnings and courses asynchronously to learn about different thematic areas in health that are of interest to you. So please be on the lookout for our messages. Thank you to all those who joined from Ghana, from Kenya. We truly appreciate you. We saw you. I saw a number of our healthcare colleagues. We will definitely be sending out information via social media handles, so please feel free to follow us on social media. We would like to thank our partners. We would like to thank Sub-Saharan Health Solutions, who will be providing the CPD to doctors in Nigeria for this session. So please feel free to send in your details. If you are on YouTube joining us, please send your details on the chat with your full name and your email address. We do have a thank you vote of thanks message from the DFC. So please play that so that we can round up. The volume is not up, or is it just from my end? Can anyone hear the video?
No, I cannot hear the video as well. Hold on, let me try.
You need to make sure that you're sharing with voice, DJ. Can we try again? Can you unmute as well? I don't think we can hear it from my end.
Thanks, Sadaura. My name is Dr. Amdi Agum. I'm a member of Doctors Foundation for Collaborative Care. This is our first webinar, and we hope the first of many. I'm very grateful to our speakers, who are also members of DFC, MDoc, Adaura, and her able team, and Dr. Ajay Obe, and Sub-Saharan Healthcare Solutions, who will be issuing CME points. The purpose of all these meetings is to improve information, skills transfer, and to work together for the overall good of our patients. Medical knowledge changes almost daily, and we're duty-bound as healthcare professionals to update our knowledge and our skills that our patients get the best care as good as anywhere else in the world. If we fail to do this, we fail in our duty of care. The whole purpose of this is collaboration, and means we all work together for the good of our patients to help each other improve our knowledge and our skills. We thank our presenters who are also members of DFC. We thank MDoc and Sub-Saharan Healthcare Solutions. They have put in a lot of work to making this happen. We thank you all for participating, and we hope you will join our other ones, which we'll be organizing soon. The flyers will be out. We thank you all and have a blessed day. Thanks, Adaura.
Thanks so much, everyone. Thank you so much for joining and for staying through till the end. We want to say a special thank you again to our speakers for the sacrifices that you made to put this together, and your time that you've also invested in passing knowledge. Thank you so much. We will send out the messages with the resources to everyone. So thanks, everyone. Enjoy the rest of your day. Till we'll meet next time. Have a wonderful month of July. Bye.
Thank you.
Bye-bye.
Thank you.